Imagine this. A man is 71 years old, retired, sharp as ever, still tending his own lawn, still driving himself to Tuesday poker games. His wife finally persuades him to visit for a physical examination that he has been postponing for 2 years. Dr. Mandel examines him and says, "Everything appears normal." Then he adds 6 words that alter everything. Let's just run a few tests. 3 months later, that same man is healing from a procedure he did not require for a condition that would never have affected him. He's coping with complications that have nothing to do with the reason he originally walked into the office. And the life he had known before that appointment, the lawn, the poker games, the independence, that way of life is gone. This situation is not uncommon. That story has a name in the medical literature, and today we are going to discuss it frankly. My name is Dr. Mandel. I am a physician focused on cardiovascular health and aging. What I specifically examine is how the body's circulatory system changes after the age of 60, and what that impacts how we approach medical decisions. In my work with adults over 60, the trend I observe is this: people who felt perfectly fine going into a routine appointment and came out the other side dealing with something they never had before the testing process began. This trend has a mechanism. It has a name. And once you understand it, you will never sit in a doctor's office the same way again. Here is the number that should make you pause. Studies estimate that between 15 and 25% of all medical procedures performed in the United States every year are not essential. But here is the part nobody talks about. That percentage increases significantly after the age of 65. Not because older patients are sicker, but because the age risk-benefit calculation shifts entirely after 65. And the healthcare system was not structured to assess that calculation during a 15-minute appointment. This phenomenon is termed the cascade effect. It works like this. One routine test detects a minor irregularity. That abnormality prompts a follow-up scan. The scan recommends a biopsy. The biopsy results in a procedure. The procedure produces a complication. And a person who walked in feeling completely fine is now handling a medical situation they did not have before they agreed to that first test. The cascade does not begin with the surgery. It begins with the first test. And that is exactly what today is about. I'm going to walk you through 5 specific medical checkups that I would personally rethink after the age of 65. Not because medicine is broken, but because after 65, the risk to benefit equation changes. And very few doctors are discussing that equation openly with you. I will show you why it changes, what I have seen happen to real patients, and I will give you a set of precise questions at the end of this video that can fundamentally alter the discussion during your next appointment. Stay with me through all 5. Number 3 is the one that surprises people the most as it pertains to a test that seems intuitively logical. And number 1, the final one, is the checkup that hardly anyone is challenging, even though the data behind it is more troubling than almost anything else on this list. Before we begin, leave your city or state in the comments right now. I read every one of them, and I truly wish to know who is viewing this video. It holds significant meaning for me to see the community that has grown around this channel. But first, there is one concept you need to understand, because without it, nothing else I say today will fully connect. I call it the longevity lens. Here is how it works. When you are 50 years old, routine screening is often one of the finest investments you can make in your health. You identify a problem early, treat it, and potentially gain 30 more healthy years. The calculation is clear. The investment yields returns. After the age of 65, 3 things basically alter that calculation. First, many of the conditions that routine screening identifies in adults over 65 will never truly cause harm. They grow slowly. They exhibit no symptoms, and in a significant number of cases, you will outlast them. But once a result appears on a medical report, healthcare does not have a watch and wait option. It has a treatment option, and that option is often pursued. Second, your body's resilience to medical procedures is not the same at 50. A surgery that a 58-year-old recovers from in 2 weeks can entail months of healing for a 73-year-old, accompanied by complications, loss of independence, and a quality of life that might appear quite altered afterward. Third, there is the cascade effect. One test, one abnormality, one sequence of events that started from a state of feeling completely well. Bear the longevity lens in mind as we go through every item on this list. All right, let us proceed, starting with number 5. Checkup number 5, routine PSA. Prostate testing after the age of 70 in low-risk men with no symptoms. This one demands accuracy because it is simple to misinterpret. I am not asserting that prostate cancer is unreal. I am not saying that PSA testing lacks value. I am saying that for men over 70 who have no symptoms, no family history, and no prior concerns, the data on routine PSA testing reveals information most men sitting in Dr. Mandel's office have never heard. Here is the central concern. A PSA test can detect a prostate cancer that is, biologically speaking, progressing very slowly. A slow-growing tumor that if left alone would never metastasize, never produce symptoms, and in a 71-year-old man would nearly assuredly never shorten his lifespan. He would coexist with it, not succumb to it. But the moment that result comes back elevated, medical practice does not delay. Biopsies are requested, specialists are approached, treatment choices are offered. And for a man who is 71 and otherwise robust, treatment for low-grade prostate cancer may involve radiation, hormone therapy, or surgery, each carrying genuine risks to continence, sexual function, energy levels, and general quality of life. The American Cancer Society revised its recommendations specifically because of this issue. For men with less than a 10-year life expectancy, or for older men at average risk who have no symptoms, the risks of finding a slow-growing cancer often surpass the possible benefits. I want to tell you about Raymond. Raymond is 74 years old, a retired electrician from Tulsa, Oklahoma. He was healthy, energetic, had no family history of prostate cancer, and absolutely no related urinary symptoms. His routine PSA test came back mildly elevated during his annual physical examination. A biopsy confirmed a low-grade, slow-growing prostate cancer with a Gleason score of 6, which in medical terms means it is as slow-moving as prostate cancer typically gets. His urologist advised radiation therapy. Raymond relied on the advice and continued with treatment. Within 8 months, he was dealing with persistent tiredness that affected his mornings, urinary frequency that altered his daily routine, and a life quality that had diminished in ways he never foresaw. When he sat down with Dr. Mandel 1 year after treatment, the words he used were, "I felt healthier before it was found than I do now that they fixed it." That statement is not uncommon. It is consistently found throughout the medical literature with a consistency that should make every man over 70 think carefully before blindly consenting to a routine PSA test. So, what should you do instead? If you have urinary symptoms, difficulty, alterations in urinary flow, increased nighttime frequency, talk to your doctor. Those symptoms matter. If you have a strong family history of prostate cancer, that alters the calculation. But if you are over 70, have no symptoms, and are considered average risk, the conversation with your doctor should not primarily be, should we screen? The conversation should be, what actions would we realistically take if something was found? And would that treatment enhance my life more than simply observing the condition? That single question often transforms everything. Now, let's move to checkup number 4. Checkup number 4, standard bone density DEXA screening leading to automatic long-term medication. Before anyone misunderstands this section, osteoporosis is a genuine concern. Falls can be calamitous for older adults. I want to be precise here because there is a difference between challenging a test versus questioning the automatic treatment sequence that often follows the test. A DEXA scan measures bone density. If the results show low bone density, numerous physicians promptly prescribe a class of medications known as bisphosphonates, including Fosamax, Boniva, and Actonel. You likely recognize these names from advertisements. The message is straightforward. Low bone density equals medication. Medication equals protection. But here is what that message frequently omits. Long-term bisphosphonate use, particularly beyond 5 years, has been linked to a rare but severe condition known as unusual femoral fractures. These are fatigue fractures of the thigh bone, the very bone the treatment is meant to safeguard. These fractures may be severe, frequently necessitating surgery, and, in some cases, cause greater disability than the fracture they were originally meant to avert. There is also a condition called osteonecrosis of the jaw. This involves degeneration of jawbone tissue that can be agonizing, slow to heal, and in some cases, triggered by the very medicine designed to fortify the skeletal system. Meanwhile, and this is the part that should be included in every discussion about bone health, the most impactful intervention for lowering fracture risk in adults over 65 is not always medication. It is preventing falls, balance exercises. Research on Tai Chi in particular has shown that it can reduce fall risk by nearly 50%. Clearing tripping dangers from the home, placing grab bars in bathrooms, assessing medications that might cause lightheadedness, having eyesight checked annually. These interventions often lower genuine fracture risk more effectively than many medications, and they do so free from medication-related adverse effects. Let me tell you about Gloria. Gloria is 72 years old, a retired primary school teacher from Phoenix, Arizona. After her annual physical examination, she had a DEXA scan and was informed that her bone density was lower than typical for her age. Her doctor prescribed a bisphosphonate that very same day and recommended she continue taking it indefinitely. Gloria came to see Dr. Mandel 3 years later after developing ongoing discomfort in her thigh. Further evaluation showed an initial unusual stress fracture. She had not experienced a fall. She had no prior fractures. She was on medication meant to avert fractures, and her bone was responding negatively to that exact treatment. So, what should you ask before blindly beginning medication? Ask, what is my true fracture risk based on my comprehensive health profile, not solely on this scan result? And can we weigh the potential advantages of medication against the advantages of a structured fall prevention program? That question is neither challenging nor argumentative. Any competent doctor should welcome it. Now, let us move to checkup number 3. Checkup number 3, standard cardiac stress testing for asymptomatic individuals. This is the one that surprises many people because it appears highly responsible. Your doctor says, you are 68 years old. Let's simply confirm your heart is functioning well. You get on a treadmill, or they administer a medication that momentarily strains your heart while its reaction is observed. What could potentially be amiss with that? Here is the issue that hardly anyone addresses in the room. Cardiac stress tests performed on people without symptoms, no chest pain, no shortness of breath, no dizziness during exertion, can have false positive rates nearing 40% in certain populations. That means that in nearly half of those cases, the test identifies an abnormality even though the heart is truly functioning normally. But medical practice cannot merely overlook an abnormal finding. That false alert often propels you into the next stage of the cascade, cardiac catheterization. A slender tube is guided through your blood vessels, typically via the wrist or groin, and steered directly into the heart. The hazards include bleeding, blood vessel injury, heart rhythm irregularities, and in rare cases, the catheterization itself may instigate the very cardiac incident the screening aimed to prevent. And if the catheterization reveals a partial obstruction, which is exceptionally common among adults over 65, including many who might live for decades without any cardiac event, you might be recommended to get a stent. Now, this is the part I genuinely want you to grasp. Multiple major clinical trials, including the ischemia trial, one of the largest studies of its kind, found that placing stents in patients with stable coronary artery disease did not decrease heart attacks or prolong life when versus medication and lifestyle adjustments alone. The stent did not exceed a 30-minute daily walk combined with appropriate medical therapy. However, it involved all of the procedural hazards and often necessitated years of anticoagulant medication afterward. So, the cascade often looks like this: feeling fine, routine stress test, false positive result, cardiac catheterization, stent placement, blood thinners, continuous monitoring, no statistically meaningful improvement in long-term results. That is the complete picture, and it all started because someone suggested, let's simply check. If you are perceiving this information as valuable, type the number 3 in the comments. It is a simple way to let me know you are following along, and it truly aids this channel in reaching more individuals who may benefit from this information. So what should you do instead? If you have no chest pain, no unexplained shortness of breath, and no dizziness during physical activity, the conversation with your doctor should not primarily focus on stress testing. It should focus on optimizing the factors that truly contribute to cardiovascular risk: blood pressure, cholesterol, blood sugar, physical activity, sleep quality. That is where the most significant cardiovascular improvements happen after the age of 65, and none of them necessitate a catheterization for attainment. Now let's move to checkup number 2. Checkup number 2. Standard carotid artery ultrasound for asymptomatic patients. Hardly anyone is discussing this topic, and based on what the evidence shows, that lack of discussion may be one of the most critical oversights in routine senior healthcare today. A carotid artery ultrasound examines the large blood vessels in the neck that carry blood to the brain. The concept sounds logical. Identify a blockage before it causes a stroke. Surgically remove the blockage. Problem solved. But the reality is considerably more complicated, and for people without symptoms, potentially more dangerous than it sounds. Here is the fact that changes everything. The surgical procedure commonly used to treat carotid artery narrowing, known as a carotid endarterectomy, carries approximately a 2 to 3% risk of causing a stroke during or immediately after the procedure. In older adults with additional health conditions, that risk may be even higher. The United States Preventive Services Task Force, the organization widely regarded as the benchmark for screening recommendations in the United States, specifically advises against standard carotid artery ultrasound screening in adults who have no symptoms. Their finding is clear. For asymptomatic individuals, the hazards linked to intervention typically surpass the potential advantages. Here is why. A substantial proportion of adults over 65 have some degree of carotid artery narrowing. In many cases, that narrowing has existed for years. It stays stable, it stays unobserved, and it never leads to issues. But when routine screening detects it, a well-intentioned specialist may recommend fixing it. The problem is that surgery performed on a blockage that was never causing symptoms can dislodge a small fragment of plaque. That fragment may travel directly to the brain. The procedure ends up creating the very result it aimed to avert. So, what should you do instead? If you have no neurological symptoms, no sudden vision changes, no facial drooping, no arm weakness, no brief episodes of confusion, and no episodes of slurred speech, routine carotid artery screening is typically not advised and should not be your main focus. Your attention should be directed toward managing the factors that genuinely increase stroke risk. Blood pressure, the most important one, blood sugar control, atrial fibrillation, if it applies to you, and maintaining consistent physical activity. However, if you encounter any of the symptoms I just mentioned, even briefly, even if they disappear completely, that alters the situation completely. Obtain medical assessment at once. At that point, we are no longer discussing routine screening. We are talking about your body issuing a warning signal requiring urgent notice. Now we arrive at checkup number 1. Checkup number 1. Standard colonoscopy after the age of 75 in low-risk, asymptomatic adults. This is the one that most individuals have never heard contested, because colonoscopies have been so thoroughly endorsed for so many years that challenging them in the right context can seem almost illogical. But the data for adults over 75, specifically those with no symptoms, previous clean colonoscopies, and no family history of colon cancer, presents a different narrative than most people have heard. The United States Preventive Services Task Force explicitly recommends against standard colonoscopy screening in average risk adults over the age of 75. Their rationale is not unclear. The hazards start to outweigh the advantages, and those dangers become quite real when you understand what can go wrong. A bowel perforation, a literal tear in the wall of the colon, happens in around 1 out of every 500 colonoscopies. For a younger adult, that may be a treatable surgical complication. For a 77-year-old, it can mean emergency surgery, a colostomy, prolonged hospitalization, and a recovery process that permanently modifies independence and life quality. And that is not even counting the preparation itself. The bowel cleansing solution required before the procedure can lead to hazardous dehydration, electrolyte disruptions, and considerable cardiovascular strain in older adults. There is also the hazard associated with sedation, which rises with age. And then we return once again to the longevity lens. The colon cancers most likely to be discovered in asymptomatic adults over 75 tend to typically grow slowly enough that in many cases they would never lead to significant issues during that individual's remaining lifespan. I want to tell you about Margaret. Margaret is 78 years old, a retired educator from rural Ohio. She had undergone 2 colonoscopies during her 50s and 60s, both entirely normal. No polyps, no family history, no symptoms whatsoever. Her new primary care physician examined her chart and informed her she was due for another screening. Margaret asked questions. She was assured that it was standard, so she consented. The preparation impacted her greatly. By the following morning, she was confused, weak, and barely able to stand. Her daughter took her to the emergency department before she ever reached the procedure. Her electrolyte levels were dangerously low, and her heart was under considerable stress from dehydration. She remained 5 days in the hospital. She never truly had the colonoscopy, and the findings from those 5 days revealed that her heart and kidneys had been strained by a process meant to screen for something she nearly certainly did not possess, and even if she had, would most likely have outlasted. When Margaret called Dr. Mandel after being discharged, she said, "I felt healthier when I was past due for that test than I did after attempting it." So, what should you do instead? Ask your doctor about non-invasive stool-based screening choices, such as Cologuard or an annual FIT test. These tests can detect significant warning signs without subjecting you to the procedural hazards associated with colonoscopy. And if you do have symptoms, blood in the stool, unaccounted changes in bowel movements, ongoing abdominal pain, or unaccounted weight loss, that changes the equation completely. Those symptoms merit medical assessment irrespective of age. Now, let us move to the useful guidance I offered earlier. Every time a doctor recommends a screening test, especially if you are over 65 and feeling well, I want you to have 5 questions prepared. Write them down. Store them in your phone. Carry them to every appointment. Question number 1. What is the false positive ratio of this test in people my age? This question tells you how likely the test is to send you into a series of follow-up procedures, even when nothing is actually wrong. Question number 2. If this test finds something, what are the practical treatment options for someone my age and health status? Do not let the discussion stop at "we found something." Push the conversation one step further, and then what? Question number 3. What is the procedural hazard of the treatment we would probably undertake? Every procedure involves risk. You deserve to understand that risk before the procedure, not after it. Question number 4. What happens if we observe this instead of treating it right away? For many conditions identified in older adults, observant waiting is a valid and often better approach. That is not surrendering. That is making decisions based on appropriate risk-benefit analysis. Question number 5. What is the most efficacious, non-invasive method for this condition? Because as you have seen today, whether we are considering bone health, heart health, or stroke prevention, lifestyle adjustments and appropriate medical management frequently outperform invasive procedures while involving only a fraction of the risk. Any physician who truly has your best interests in mind will accept these questions. They will not make you feel troublesome for asking them. And if a doctor disregards those questions or makes you feel like a challenging patient simply because you ask them, that is valuable information about whether that doctor is suitable for you. Here is what I urge you to do starting today. Before your next appointment, Whether it is next week or 3 months from now, write those 5 questions on a note card or store them in the Notes app on your phone. Do it today. Carry that card with you. You may not need all 5 questions. You may only use one. But having them ready alters how you enter that room. And how you approach that visit can influence the decisions made about your health. Attempt this for the upcoming 30 days. One appointment, those 5 questions, and I can tell you what you will observe. By the end of those 30 days, you will feel like an empowered kind of patient, not a challenging patient, a safeguarded patient, someone who comprehends why tests are being requested, what the follow-up procedures mean, and what inquiries should be made before the cascade starts. There is likely someone in your life, a partner, a sibling, an adult offspring, or someone assisting with care for elderly parents who needs to hear what we covered today before their next annual physical examination. You do not need to explain it all personally. You can just forward them this video. If this conversation has altered your perspective on routine medical care after the age of 65, subscribe to this channel. Next week, Dr. Mandel will be discussing something that relates directly to everything we discussed today. Particular medications that are regularly prescribed to adults over 65, but involve a completely different risk profile at that age than they do at 50, and the questions you ought to ask your pharmacist before refilling them. If you consume more than 2 daily medications, that video is for you. Leave a comment below. Has a routine medical test ever led you somewhere unexpected? Your experience in the comments might be precisely what someone else needs to read before walking into their next appointment. Look after yourselves. I am Dr. Mandel, and I will see you next week.